I would like to invite Dr. Mughis Sheerani. Dr. Mughis Sheerani has always worked hard for promoting the neurology in Pakistan through the continuing medical education activities and by raising the professional expertise among the neurologists and the general physicians. And I have no hesitation in appreciating his contributions and efforts in participating in different awareness programs. So please, Dr. Mughis Sheerani.
Good morning, and thank you for, especially Dr. Nadir, for inviting me for this talk. Actually, I'm not a Parkinson's expert, so my field is epilepsy, so I was thrilled to look into this, and I just found a couple of papers and looked into new things, and actually I did find a new medication. Dr. Jawad will know about it, the new carbidopa, levodopa formulation, so I'll tell you about that. It was just in the supplement of Neurology. The topic is medical management of Parkinson's. I was thinking that if it was management of Parkinson's disease, it would have been more difficult. And the thing is, as you grow older, you realize that Parkinson's disease is one of the toughest disease to manage because it's a neurodegenerative disorder. And here it comes the art of medicine rather than science of medicine. And as we age, we find out that it is not just the medications, and medications are not the answer. And sometimes doing less is actually doing more. And so you have to, so what I would do is basically, I have put a couple of slides. You can ask questions in middle. It's kind of workshop thing. We can wrap it up in 15 minutes, but there are medications available, and how I learned about those medications and what the literature shows about those medications. So I just like this thing. So, I used to hate Hitler a lot, but poor guy had Parkinson's. So his stern face was not just, so we talked about mass species, so I always put this, but there are a lot of great people who had Parkinson's disease. I actually did not know that Yasser Arafat had Parkinson's disease too. But if you look at his life, it was a very full life. So a lot of these people had very full life, and I used to watch his movies from Back to the Future and now Spin City and all that. So you know that people have done a lot of, led a full life with Parkinson's. Okay, so we talked about it. So I just put this slide up. So we'll talk a little bit about cardinal motor symptoms and then non-motor symptoms. And as practicing neurologist, I would tell you, motor symptoms are easy. They're like piece of cake. I think the non-motor symptoms are the worst kind of challenge for a neurologist. And you will see that coming back to surgical talk, I think they want to make sure that there are not many non-motor symptoms before you go for that. So I think that is what bothers. So the bradykinesia, muscular rigidity, resting tremor, and postural instability are the main things. But in non-motor, there are a lot of things. And I found a paper, and they did kind of look at every aspect and what medications actually work. So we'll just go through them quickly. So I just found this slide on the net, and if you look at levodopa, it's still the main treatment for Parkinson's disease. And I don't know how many you have watched that movie called Awakening, and it was found that, and actually there was a book, and these were old people who were sitting in a nursing home, and they were given this medication and suddenly started dancing, and that medication was found to be levodopa, carbidopa, and the levodopa. So as you know, dopamine does not go into the brain, so you have to have carbidopa. And then you had, when I was doing my residency, then we had this medication called telcapone and then entacapone, and basically for catecholamine O-methyl transferase activity and reduction, so that you can actually have more dopamine in the brain. So you're trying to get more dopamine in the brain, and by different methods. The older medications that are not available anymore are pergolide, and carbacoline is still available, but pergolide, and so the ergot based medications are not available anymore because they used to cause a lot of nausea and vomiting. But newer ones are like rotigotine, apomorphine, pramipexole, and ruperinol. So when I was getting trained in US, this medication came for, which was called primary Praxol. They named it Miripax, which is a miracle drug for Parkinson's disease. And it was kind of miracle in the beginning. But then we found out that patients were suddenly sleeping and having car accidents and dying because of car accidents. And because it used to cause a lot of sleepiness, drowsiness. And there was a bunch of studies afterwards trying to figure out whether Parkinson's causes sleep disorder or whether it's the medication. It turns out both have problems. So if you have all these armamentarium in your medication list, but you have to know these side effects very well before you start these medications, because most of them have some kind of effect on Parkinson's itself and the effect on the disease. But eventually you are trying to get dopamine into the brain. One of the medications called imantidine, which is actually an antiviral medication, improves dopamine, and it's a dopamine agonist. So you can go by the route of dopamine agonist, or you can go directly as dopamine, as in levodopa. So how would you like to do it? And then there are medications like anticholinergics, which have limited role but actually work for tremors in Parkinson's disease, but would not work in rigidity, but would work in tremors. And particularly in older individuals, you have to be very careful using these medications because they have all those bad side effects that you do not want in older individuals, like urinary retention, memory problems, confusion, disorientation. So they have kind of gotten out of fashion for late Parkinson's disease. This definitely has Parkinson's disease, I can tell you. So algorithm in the management of Parkinson's disease. I found this slide. This is kind of interesting. So you have, I think this is the most important, the non-pharmacological therapy, which includes rehabilitation. If you start there and then move to pharmacological therapy, then it will be much beneficial for the patient. I think jumping on to medications right away sometimes is not a very good idea. So there are evidence that there's some medications that can actually have a neuroprotective role, and some people use a lot of neuroprotective medications, which can be either way from coenzyme Q10 to sledgiline or zegeline, but they have shown some neuroprotection. Then there are, when you start getting functional impairment and the patient actually tells you that now it is time that he needs some help in the medication, I think that is the best time to start medication. Now there are two groups, experts, who talk about whether starting dopamine agonist first or levodopa first. So मेरे ख्याल हम लोग सब मुसलमान ही बैठे हुए यहाँ पे. So I tell my patients that there are two, one एक बरेलवी group है और एक क्या होता है वो देवबंदी group है. So basically one group would say start dopamine first. Some other group would say start dopamine agonist first. So whichever you are Deobandi or Barelvi, I think both are okay. My जो वो है group is actually dopamine agonist. So I know Nadir has a different thought. Nadir is basically dopamine group. So there are evidence for both, fortunately or unfortunately. Some people actually think that dopamine is neuroprotective, and why wait for that? As growing older with neurology, you find out when you start dopamine, you have dyskinesias and on and off phenomena. We'll talk about that a little bit too. But that is up to you. Whichever authority you like, you can actually. So I go with dopamine agonist route, and then you can add later whether you can go into that. And then we'll be talking about surgical modalities later if that fails. So these are all the medications and the doses. I will not go into detail, but there are a lot of evidence references about how much doses can you use. And basically what you are trying to do is go to the maximum dose of one medication and then add one. Sometimes for example, medication ropinol, you can go up to quite high dose of 30 or 36 up to 24 milligrams. And sometimes we stop early and we think that patients are not responding. Some patients respond at higher doses. Unfortunately, in higher doses, then you have a lot of side effects too. So you have to kind of manage that. That is the art of medicine, I think. I don't know about Jawad. This is really slow. So my consultant, who was a Parkinson's patient, he had the slowest clinic. One patient would come in, one patient would go out. So he would say only 10 patients, other would say 20s. Now this is again the pendulum that we are talking about. So I found this in this current pharmacology practice where this is where that pendulum that you have, where do you want to keep it, whether you want to keep it toward levodopa or dopamine agonist. Here, if you are on this side of the pendulum, what you are seeing is, you see less motor fluctuations, less dyskinesias, and delayed onset dyskinesias. If you are on that side of the pendulum, you are getting them better motor efficacy. But what you want to be in the middle. So you want to do something which comes with lot of practice and lot of when you see a lot of patients, how to keep this pendulum in the middle. I think that is where you want to keep it. So remember this slide, whether when you are seeing a patient and you are targeting him. So this you have made the diagnosis. Whether you want to treat, no, that is okay. Like, you don't want to jump to the treatment, you just want to send them to rehab, you want to do some physiotherapy, you want to give good lifestyle, that is okay. If you decide about the treatment, then you say you have like 3 basic kind of areas. Minimal motor disability, cognition is normal, you can go to MAO inhibitors like selegiline, rizagiline and all that. And if you have mild to moderate disability, less than 60 years of age, I think dopamine agonists would be better, because you will be with these patients. Some studies have shown that actually dyskinesias can come even within few years, even 1 or 2 years of on and off phenomena can develop with levodopa. So this is my kind of thinking too, that I start usually dopamine agonists if they are less than 60. If they are above 60, then probably, as this slide shows, that you can start directly with levodopa. Now this is a paper I found, and actually this was just, I don't know, Dr. Jawad has any thing. This is an expensive medication. This just retrace the name of the medication. Now so you can read the whole thing, but basically what they have done is combined the short-acting levodopa and a longer-acting levodopa in a same pill or a capsule. So this supplementary article was just supplementary on Neurology was just like about 2 months ago. So this is very new, and people don't know how to dose it still. But what happens is that the immediate release dopamine goes into the system right away, and then you have slow release that releases afterwards. So this is something that has shown that you would not have that on and off phenomena, and they're saying this is a breakthrough. That's why they actually put it in a supplement of Neurology journal. So this might be something there for our patients. It's still expensive, but it's not that expensive. It's about they were talking about $20 or $25 per day of treatment. So hopefully this would, when it would become cheaper. So this is basically levodopa, carbidopa, oral extended release therapy, and it comes kind of in microbreeds. And there was a very nice discussion between 2 doctors who were in the trials and who have prescribed this, and they have very good reviews about this medication. So we'll see how this goes, and it might help us preventing the dyskinesias. Now this was basically for the motor symptoms of Parkinson's. We'll move on to non-motor symptoms of Parkinson's, which are, as Dr. Jawad talked about it, that there's so many non-motor symptoms of Parkinson's, which include dementia. So we'll talk about neuropsychiatric disorders, cognitive impairment, autonomic disorders, and sleep disturbance. So this was the article actually that I referred to. This is relatively a newer article, but I think 2012 or 13, and they reviewed every medication, and it will help you in your practice guidelines where you would, these are kind of practice guidelines. So conclusion on drugs to treat depression included depressive symptoms in Parkinson's. So they put like all the medications. So you can find this article, but this is interesting that what they found, whether it is efficacious, whether it is safely acceptable, or whether there is clinical practice implications that it will improve your symptoms. So some of them, so they looked at double-blinded placebo-controlled trial, they looked at a lot of studies, and then kind of came up with this evidence. So if you look, most of them has insufficient evidence, but you can still say likely efficacious, in nortriptyline or disipramine, and then you can say it is possibly useful or probably useful. But if you look at some where they say that actually the risk has more, this nifedazone has more risk, unacceptable risk, so they kind of would not want you to use that. Now, if you have sleep and wakefulness disorders in Parkinson's disease, for example, REM behavior disorders and all that, they have recommended few medications too. So if you look at again the efficacy, and so for insomnia, again, if you look at, there are a lot of insufficient evidence, but if you look at melatonin, for example, a lot of people use it, insufficient evidence, and both ways, efficacy and safety wise. But if you look at acceptable risk without special monitoring, most of them would be okay in this class. Modafinil, for example, have insufficient evidence for daytime somnolence and sudden onset of sleep right now, so they are not recommending it. Now, conclusions on drug to treat fatigue in Parkinson's disease. So there are two medications that we use for fatigue, methylphenidate or modafinil. Again, both had insufficient evidence, both for safety and efficacy, but people do use them, and they are still, practice implications are still investigational. Conclusion, the drug of treatment of dementia. So you have, as we talked about, there is dementia in Parkinson's disease, and so if I looked at all these medications, I think rivastigmine is found to be efficacious. In the trials they looked at, they also found it as clinically useful. So if you come up with this slide and you look at what do you want to treat patients of Parkinson's for dementia, I think it would be rivastigmine. Again, memantine has acceptable risk without any specialized monitoring, but has insufficient evidence. So if you can take this from that slide. For pathological gambling, and I don't know where it could be abnormal behavior too, it can be pathological shopping maybe, but if so imantidine has insufficient evidence but acceptable risk without specialized monitoring, so imantidine can be used for pathological gambling that can occur with Parkinson's disease. Conclusion, drug treatment psychosis, and this is important I think, and we use that too, and we find this a lot when we treat patients with Parkinson's disease, and so they rated only 3 medications. So if you look at olanzapine, for example, they say unacceptable risk. You would not be using definitely risperidone or older dopamine blockers because of the fact that they would cause worsening of Parkinson's. But we all know that clozapine works very well. But the monitoring problems is an issue. But it is efficacious, acceptable risk with specialized monitoring. It is very good and clinically useful. But what we end up doing is usually using quetiapine, which has insufficient evidence but acceptable risk without specialized monitoring. So clozapine and quetiapine, if ideal would be clozapine, but you would not be using olanzapine or other medications as antipsychotics for Parkinson's patient. For autonomic dysfunction, there are a lot of medications available. I think if the slide comes up, it's a busy slide. So you have tons of medications that we can use for orthostatic. There is droxidopa now available. I don't think in this paper they have reviewed it, but if you look at them, most of them unfortunately have insufficient evidence. So you're doing it, but when you review the literature, you don't find much evidence. But they are also safety-wise, if you look at them, there are very few that are that have unacceptable risk. For example, metoclopramide, they're talking about here, insufficient evidence, unacceptable risk, not useful. So if you want to stay away from one of the medications in gastrointestinal problems, you want to stay away from metoclopramide. But you can use domperidone, but metoclopramide would not be a good thing. Again, you want to look at which can cause safety problems. So in all the slide you can see metoclopramide is the only one. But otherwise most of them can be used, but they have insufficient evidence and they remain kind of in investigational things. So sexual dysfunction, people are using sildenafil. You'll be using Botox, for example, for siluria, and there's glycopyrrolate and for urinary frequency, but all of them have insufficient evidence but actually are acceptable risk. Now I'll just have 2 more slides, and once you start treating, and how would you go about when you have complications of this treatment. So this is, so what you start getting into trouble when they start having hallucinations and delirium, maybe because Parkinson's itself, or whether it is because of the medications. So what you do is, if you think it is other medications, you look at the medications armamentarium and look at the medications that you can stop. If you think that it was medication induced, I think first you will look at anticholinergics and stop them, and then you look at imantadine, which causes a lot of hallucinations. Then you can look at sledgiline, and then you can look at dopamine agonist, and then still they have hallucinations. You have to reduce your levodopa carbidopa and begin with low dose. So then you get stuck and you say, no, I have to give them some levodopa carbidopa. Still they have hallucinations. Then you go to the route where you can start low dose clozapine, and as we talked about, you can get to quetiapine. So this is another way to combat the delayed side effects of Parkinson's. Thank you so much. Thank you.